Good morning, everyone. I'm Robin Shapiro, the board chair of Health Advocate X, and it feels like a long time since we were last all together, but we're delighted that you've been able to join us this morning for community conversations. I'm actually in Canada, in the little town of Qualicum Beach, and I would just like to recognize with gratitude the traditional land and territory of the Coast Salish, Comox, and Wee-Why-Kum land, who called the land home before the settlers, and in many cases still call it home. So beautiful here, and we're so lucky, very fortunate to have our board member and medical director at Swedish Health Services of OBGYN Quality and Safety, Dr. Dale Reisner, who's going to walk us through all the very robust data and questions around COVID-19. And Dale will give us a little insight also into what's happening with medical professionals across the country, which I think will be really helpful in your practice as well as in your personal health. So with that, I would like to turn it over to Dale Reisner. Dale?
Hi, welcome everybody. I think that we are all just tired of this virus. Really could move on. The virus doesn't want to move on. It wants to keep growing and keep changing its character a little bit. And so we're really hoping that what I discussed today is something that's valuable to you. And I will briefly start with numbers, but I'm not going to focus too much on the numbers. Where we're at with global cases is greater than 225 million cases across the world and almost 4.7 million deaths across the world. And again, we've talked about this before. That is not probably catching everybody because there are many places where people are dying and they could have COVID and no one's testing. At this point, there's not much point to do that. And the other concern, and we can talk about this a little bit, especially if you have questions about it, is people that are not going in for care when they find a breast lump or when they have a delay in their symptoms, or the unfortunate 72-year-old man in the South who went to 5 different hospitals with his heart attack symptoms and died of his heart attack because nobody had room. So those kinds of deaths are heartbreaking because probably, at least he had a chance of survival had he been able to be admitted to a cardiovascular unit. And those are hard to tabulate. So in the United States, we have almost 41 million cases to date and 656,000 deaths directly attributable to COVID-19, one of the variants. And right now, and you'll know it if you live in one of these states, California, Texas, and Florida have the highest transmission rates in the country, and not far behind them, Arizona and a lot of the East Coast. Now extending sort of all the way up the coast. It was more in the South for a while. So it is, COVID is alive and well everywhere. The other thing that you'll see, and we see this with our vaccination rates as well, is that the infections and the deaths are quite different in rural versus urban areas. And in highly unvaccinated states, the cases are really high and the death rates are really high. What we are seeing in the Pacific Northwest is an increase in pregnant women having COVID. And this is probably because pregnant women were not included in the original trials on purpose. And there were some early pregnancies that were detected sort of after somebody was participating that showed no problems. And so our original discussion about vaccination was very much based on a balanced discussion with the patient, that none of our national organizations had any concerns about the vaccination, but obviously it was up to them. And a lot of them had been thinking that they would wait till they were done with their pregnancy and get vaccinated afterwards. And that has totally backfired. So we are seeing sick, intubated, pregnant women delivering early to save the mother's life at very young ages. Sometimes it's heartbreaking, especially since these are adults that have opportunities. So I'll just, because this is my specialty and it's gives me the shivers just to even talk about it. If you know anyone in childbearing years, please encourage them. And we are actually being very directive with our counseling now, instead of the here's your options kind of thing. Obviously, some people won't want to get vaccinated ever, and we don't want to be disrespectful to those people. But the way of looking at it, and I'm going to share a story which really highlights this, is that whatever I do as an individual potentially can affect hundreds of other people that I may come in contact with, either for the good or otherwise. And for us to think about how we do live in a society, and that my own personal needs, of course, are what I'm going to focus on, and then my family, and then the people all around me. But we live in a community, and if the community is not healthy, then we will not be healthy either. So that's I guess a good message to kind of carry, irrespective of your own personal belief as an advocate in vaccination or not, that we need to support the science and need to support the health of our communities and your clients. So speaking about that, so now people always ask, Delta has really just taken over, and Delta is what is crushing all of the West Coast. It's so easily transmissible compared to the original COVID-19 virus. And more and more variants are around. There's quite a few of them, but leading after Delta now in the US, we are seeing a Lambda variant and now a Mu variant. So they're naming them all after the Greek alphabet. I don't know what they're going to do when they run out. As long as there's a host for the virus to establish itself in and grow well, it will continue to mutate. So don't be surprised if you see other mutations. They are pretty much acting similar to Delta. As best we can tell, they're still overwhelmingly across the country. What we're seeing is primarily Delta.
And when people go in to get tested or diagnosed, do they know what variant they have, and is that important for the ordinary person to keep track of?
No, they don't, and it's not that important for the ordinary person because they're all transmissible, and they all can make you and your family and your friends sick. So each state is a little bit different. The state of Washington is sampling about 5%, sometimes a little bit more, of the samples that they get to look at the variants. So the variants are more of scientific information. Also, as they come around and seem to be establishing themselves in a given community, to know if they are more infectious or creating more severe disease, it's helpful for epidemiologists and public health people and caregivers and providers to know that, but you don't need to know that as an individual. And the vaccines are still doing what they're supposed to do. So they are not as effective. And we never had any vaccines ever that were 95% effective. So I think it was a little bit of a fairy tale when it first came out, and they were with the original virus. But like our flu vaccines range from 60% to 80%, depending on the year. And I think we'll see that with the vaccinations for COVID. And they will continue to modify them as they make them, as these new variants come out, trying to be more targeted towards those as well.
So question about the flu vaccine, because you just brought that up. So I'm assuming that we all should be getting vaccinated for the flu, and we will be having a flu season. Question
We
mark?
are, I would guarantee that we're going to have a flu season this year. So
Okay.
last year, why didn't we have one? Because we were running around very masked. We were not having, at least many places in the country, we're not having in-person large events in closed spaces. A lot of the country was shut down. That is not the case now. Schools were shut down, and schools are the best place to pass flu around. The kids usually don't get it as badly as their grandmas do, and that kind of thing, right? So we are expecting a flu season, and so yes, get your flu shot. You can get your flu shot with any other vaccination, just like you can the COVID vaccine. And I'll just briefly mention now, right now, across the United States, if you look at the total country, almost 76% of adults are vaccinated with at least one dose. So even one dose will give you about 60% coverage. The two is higher, of course, when it's Moderna or Pfizer. And
So
then the J&J
76% of everybody in our country.
in the US, yep,
Okay.
has at least one shot. Okay.
Adults, though, adults.
Adults,
Mhm.
not the children, because remember, we've just opened up that and not pregnant adults, right? So what we have to think about is, okay, 75, 76% sounds pretty good. But where are people getting infected? They're getting infected in the pockets that aren't vaccinated. So that 75, 76% is not uniform across the country or even across a state. So we're finding, rural areas less well vaccinated for a variety of reasons. Urban areas better, some states better. And where you're seeing the better vaccinations, we're still seeing cases. We're not seeing the deaths, and we're not seeing hospitalizations as much. So I work in the Swedish system, which is three hospitals. It's a bigger system than that, but three that deliver babies. And we, every single sick patient that's had to be admitted has not been vaccinated. And our ICUs, same thing. So it's super rare. And when you look across the country, there have been a few reported deaths from vaccinated people. They all have comorbidities. So they're older, they're heavier, they may have hypertension, diabetes, other immunosuppression. And so the thing with pregnancy is that when you're pregnant, you're a little immunosuppressed. Mm-hmm. And that's protective, because otherwise we would reject our babies that have somebody else, not me, right? So it's the right thing, but it means we're in pregnancy. Typically, viral infections have a bigger impact for pregnant women than they do, and this virus is devastating. It's causing some high blood pressure that's transient, causing deliveries, causing people to get really sick. Asthma, even mild asthma, if you have that, you might not think of that as being a comorbidity, but it is when it comes to a respiratory virus like this. So, and that's, whether you're a child or a pregnant person or an adult of any age.
So I have a question about, I'm just kind of zooming in on that 76% of the entire country's adult population. Right. So we don't hear a lot about herd immunity anymore. So is that not possible? I mean,
yeah, it's possible. It really is. I think that we're not going to see it when we have large pockets of unvaccinated people, and everybody has been traveling more, right? So we have people traveling, and so they're getting exposed. And the thing is, if I am fully vaccinated, I'm looking forward to a booster. We can talk about that later. And I have not been flying, but I might have. Like, I was going to go on a trip that just got turned to a virtual meeting. So when you do that, even if you're masking, you're in close quarters and you can pick something up, or in the airport, you can pick something up, and people have let their guard down. So you've anyone who's been on this call before have heard me say, I don't go into the grocery store, even fully vaccinated. I do not go in the grocery store without a mask. When we were told that we could not mask, I just didn't feel comfortable doing that. And that's exactly how we're going to have to be for a while, I think. So it is that I could get sick, and because I could get sick, I might not have symptoms, but I could easily pass it on to somebody else.
Mhm.
And that's where we're having issues. Yeah.
So
We still have kids in school
Yeah.
now that will be, which is also where that probably will feel the flu issue as well.
Yeah. Can I
yeah.
press a little bit on the masking issue, which is,
Yeah.
it used to be that any kind of masking was okay. And so people were wearing any kind of mask. And I've read more recently, I don't think we talked about this in prep, but that actually cloth masks don't provide the protection if you're going to be exposed over a period of time, and that people should think about getting those KN95s or, the more robust
Surgical mask or whatever.
Yeah,
Even
yeah.
a surgical mask, which are a lot less expensive, and they're meant to be one-time use and so on. And certainly if you're around somebody that has COVID, I would definitely have the more intense mask.
Mhm.
But a number of these cloth masks are made with multiple layers and have a little insert for a filter, and they should
Mhm.
work pretty darn well. You
Mhm.
just have to remember to clean them and remember, how to take them off so that we're not contaminating ourselves, and to clean them probably more often than what we've gotten used to doing.
Yeah.
I mean, even I have one in my purse, and I don't always take it right out. I'll
Yeah.
use it a couple times during one day. It's probably okay. And the biggest thing about masking is keep your nose covered, keep your mouth covered.
Mhm.
Don't do a lot of hands around.
And no gaps.
And no
That's what I
gaps.
have.
Right. So so find the mask that's the most comfortable for you is what I would say, and definitely want multiple layers, not just a single layer. And the gaiters are not useful. They're probably useful in that if somebody's wearing a gaiter properly and I'm around them, they're probably not spewing directly on me, but we know that those particles will go through the layers of cloth for a bandana or a gaiter.
Mhm.
Yeah, I have a question real quick.
Yeah.
You said it's in the 70s for one shot, but I heard that our country for adults is at like 56 or maybe
For
52
for
for
fully
fully
vaccinated.
vaccinated. Is there,
Yeah.
so, I mean, sure, there's people that aren't getting the second shot, but if they have one shot,
Mhm.
how protected are they? Like what, I mean,
They should be, well, the effectiveness after one is in the 65% range.
Okay.
So they still can get sick,
right, but it's way better than.
way better.
Yeah,
Way
okay.
better. Yeah. And then from a variety of sources, this was interesting, and I didn't know this number, but from a variety of sources, they have determined that probably around 14% of the population in this country will never get vaccinated. So there, for a variety of reasons, they either probably will not or definitely will not, based on either interviews and a variety of other tools that they use to assess that. So if that's the case and everybody else is fully vaccinated, we'll probably be in very good shape anyway. But it doesn't mean that I won't go into the store without a mask,
Yeah.
So let me read you something.
One last question
yeah,
before
sure.
you get in. So Judy Finn wants to know what the interval between testing is needed to provide satisfactory protection. The interval between testing.
Between testing or dosing?
So she says testing. So if you've had a test.
Let me talk about that in just a sec,
Okay.
if that's okay.
Yeah.
Because
Okay.
I did pull up, and we didn't talk about this in our prep talk,
Yeah.
but I know people are, I get calls from my family too
Yeah.
on this. If you've been exposed or potentially been exposed, how do you behave? What do you do? So that
Yeah,
might be what
good.
she's getting
Yes.
at.
Great.
And so, but let me read this, because when we're talking about vaccination and potentially getting sick, there's some stuff I want people to know about. And so this was an article written by Will Stone, who's a reporter. Like he reports for a variety of agencies, and I know NPR is one of them. So he starts with this: as a reporter who's covered the coronavirus since the first confirmed US case landed in Seattle, where I live, I should have known what was coming, but there was some part of me that couldn't quite believe it. I had a breakthrough case of COVID-19 despite my 2 shots of Pfizer vaccine, the second one in April. So that's him. The test results that hot day in early August shouldn't have surprised me. All the symptoms were there. A few days earlier, fatigue had enveloped me like a weighted blanket. I chalked it up to my weekend travel. Next, a headache clamped down on the back of my skull. Then my eyeballs started to ache. And soon enough, everything tasted like nothing. So the other piece of this is just 2 more areas to talk about that come directly from him, because it really, really tells it all. So he says, I was just one more example of our country's tug and pull between the fantasies of a post-COVID summer and the realities of our still raging pandemic, where even the vaccinated can get sick. Not only was I sick, and this is the kicker, but I brought the virus home and exposed my 67-year-old father and extended family during my very first trip back to the East Coast since the start of the pandemic. And right, aren't we all human? Don't we all want to do that? It was just the scenario I tried to avoid for a year and a half, and it was definitely not what I'd anticipated. So he has some other interesting insights, but I just felt like this is really what it's all about. You know, he traveled, he wasn't masking out in public all the time, kind of thing. And he was socializing in a way that he felt okay with. And yet he knows the facts. He wrote reports on it, So I think it's super important for us to think about that, because, before his symptoms showed up, he was probably contagious. We think it's not a lot. It's not like some of the viruses where you may be infectious for like a week before you get symptoms. It's probably within 48 hours, maybe no more than 72 hours before you start getting symptoms. But the symptoms can be tricky. Like I recently got tested because I took my son back to Canada to school, and I've been kind of starting to get nervous because I have year-round allergies and they're not good right now. And, have itchy eyes. So that usually tells me that's what it's all from. But I scratchy throat occasionally, that kind of thing. So, those symptoms are much more nebulous than what we thought when we first started this pandemic. So we just have to be careful with ourselves and with each other. So if you think you've been exposed, I'll just launch into that a little bit. The CDC, and this is a little confusing. So the CDC's recommendations are, if you've not been vaccinated, you need to quarantine for 14 days, okay? You should get tested 3 to 5 days after your exposure. And this is like within 6 feet of someone for 15 minutes or longer. I mean, it doesn't take a lot of time with this.
Wow,
that's variance.
Surprising.
Yeah. And if you've been, in and out so if it's cumulative, then, you have to count that cumulative time, not just sitting in front of somebody for that length of time. So unless you've been fully vaccinated, if you have been fully vaccinated, you don't need to quarantine. However, unless you have symptoms. So if you've been exposed, you hear about it, 3 or 4 days later when somebody gets their symptoms and gets their test back, and you have symptoms, then you should quarantine, get tested, even though you've been vaccinated. But if you've been fully vaccinated and you have no symptoms, especially if your contact was not extensive, then you do not need to quarantine. And then what you would want to do is still make sure that if you're out in public, you're masking. And so that on the off chance that you develop symptoms late after the exposure, you're not going to get a whole bunch of other people sick. So that's a little bit confusing, but I think it makes it a little bit more practical for those of us that are vaccinated to still be able to, work if you need to and that kind of stuff. But if you're out in public, vaccinate. If you're quarantined, like I said, it's 14 days, and if you have symptoms, you need to contact healthcare provider right away. And then isolation is used really for COVID positive patients that are sick, like within your family unit, where they stay in their own room and don't come out very often, and if you can give them their own bathroom and things like that. So if you were to get COVID, and you've been vaccinated or not, right, and you're early in the process, there's a number of things that would allow you to have access to monoclonal antibodies. So what are monoclonal antibodies? Well, they're produced by cloning white blood cells that are targeted, in this case, to the spike protein on the coronavirus. So all these variants have the same spike protein, and they were tested initially for sicker patients, and they did not ameliorate the disease process. But where they are helpful is if you are positive and asymptomatic and at high risk, you may be able to avoid any significant symptoms, and particularly hospitalization and death. And so if I'm fully vaccinated, which I am, and I am older, I would jump to get those monoclonal antibodies. So I can't give you specifics for wherever you are in the country, but there are websites, and I don't know if Robin or Beth want to mention the resource that we did have on how to get enrolled. They're not just something you go to the pharmacy to get. So they are approved by the FDA under emergency use authorization, which is how our COVID vaccine first started. Now our Pfizer is fully vetted by the FDA. I think Moderna is due any minute to be fully vetted. And so these are currently under emergency authorization. So there's a little bit of a process where you have to go in, you get registered for it, they make sure you don't have any exclusion criteria, and you go in and get an infusion. So it's an IV infusion, and you're monitored.
That's after you have COVID, you're COVID
you have
positive.
A COVID positive test or COVID symptoms that, when your test comes back positive, can be any kind of accepted, like the PCR, the NAAT, the ones that are more reliable.
Yeah.
I just put it in the chat how you can access
how you would access it. You need to go through your provider, but your provider, depending on who they are, may not be aware that how available they are in the local community. You cannot need oxygen supplementation. So most of the time, the folks that we're admitting to the hospital are too far along in the process, but their contacts may not be. So and for our pregnant patients who are getting tested, and we're offering the monoclonal antibodies to them, we have no concerns about safety in pregnancy. So that's
a really important kind of insider tool for advocates to know about, is because patients, if they are not vaccinated and they do get COVID, or if they're vaccinated and get COVID, that's a really good thing for advocates to be able to understand. And so that's very valuable. Very valuable.
You have to be within 10 days of the the COVID positive test and your symptoms. Say you have symptoms 2 days before you get your test. So it would start with you the 2 days of your symptoms. But yeah, it may save you a lot. The other thing is that reporter, his quotes mild disease was a temp of 103. It took him a month to recover. I mean, mild is not what I know, I would normally say mild in everybody. So the other thing, which we will, I'll probably mention this now, and Robin, you can take off on it if you want to now, is mild disease can result, and mild disease in a vaccinated person also can result in long COVID. So we're going to have some talks on long COVID coming up. Do you want to talk about that a little bit, Robin?
Yeah. So long COVID, for those of you who are interested. So at our conference, which is November 4th through the 6th, we actually will have 2 speakers talking about long COVID. One is Diana Berendt, and Beth put in the chat Survivor Corps as a really great resource. And Diana Berendt actually is the founder and one of the first survivors with long COVID of Survivor Corps. She's actually going to be our opening speaker. You guys are hearing this first. We haven't even announced this yet, but so you're getting the first unveiling of some of our speakers. So if you go onto our healthadvocatex.org website and register for the conference, you'll be sure to hear her. And then we also will be having another speaker who's going to be talking about, from the physician's perspective, on how to treat long COVID, a care map. And advocates on the line might know that it's very difficult to find physicians who will actually treat long COVID, right? Because we're just learning about the symptoms. So at our conference, you'll be sure to be well armed about that. So please register. Early bird deadline's coming up, and we'd love to see you. It was super fun last year. So just a little plug for our conference. We do have a couple of questions here, Dale. One is specific to pregnancy. It says, when you referred to pregnant people increasingly getting sick now, were they vaccinated? Would you discourage a 6 months pregnant person taking a flight from Seattle to DC and back at the end of September, going to the hotel, going to a wedding and staying in a hotel?
Yikes. So vaccinated, if they're vaccinated, first of all, I would strongly encourage that person to get vaccinated if they've not been. But the ability for them, if they've not been, to get vaccinated and have 2 or 3 weeks post-vaccine is not really out there. So unvaccinated, I would not recommend that they go. Vaccinated, yes, I think you could go. I would encourage them to be masked. I don't know if they want to go to a wedding masked. And it is devastating. I just can't tell you how devastating it is to watch these unvaccinated folks get sick. With a vaccinated pregnant person, I think if they are aware that they are at risk, wear a mask indoors. And if they had any symptoms at all, could take advantage of monoclonal antibodies. It just feels like a lot of if. Everybody makes their own decision. So yeah, the unvaccinated, I think you're really taking a risk. So yeah.
And is that
Gail, if pregnant, I had a call from someone. If pregnant women have preeclampsia or other complications of pregnancy, they still should be vaccinated. There's no reason to not get vaccinated.
There's no reason to not get vaccinated. Yeah. There really isn't, unless there's some other medical reason. There are very, very few real medical reasons to not get vaccinated to these RNA vaccines, or what we're recommending for pregnant women, not the Johnson & Johnson, just because of the little bit of the clotting question. And pregnancy is a pro-clotting condition. So in order to get those vaccines, that you have to be, thinking about it. And again, that we want them to be careful when they're out, when they're indoors in public places, even with the vaccinations. We've not, from our clinical perspective within our system, seen patients sick with that are vaccinated in pregnancy. So like I said, all of them have been. The other thing I guess I need to highlight, and this is, I'm not trying to be rude to anybody, but when you think about comorbidities, and when I was talking about monoclonal antibodies, or even just your risk of getting sick from the virus, older age, greater than 65, we all kind of know about, obesity or being overweight. So being overweight is a BMI of greater than 25, which is not very much extra weight. Not very much extra weight. That's exactly right. And so, and even with teenagers that are overweight. So this is who is getting sick. Yeah. And
do they know why?
All I know is that certainly in significant obesity or really high BMIs, it's really kind of an autoimmune condition is going on there. You get this inflammatory response as you accumulate more fat cells. I don't know that anybody really even understands why that's the case, but it's why when we look at medical complications with a bunch of different things, the higher the body weight, especially BMI. BMI is not the be all to end all, but it gives us a little bit, because at least it's height versus weight. And that seems to add extra risk. And so the thought is this sort of chronic inflammatory response that your body has as you accumulate greater weight.
Interesting.
Wow.
So we do have a few questions here. I mean, there's so much to talk about, right? So is there any way around, this is from Nicole Rochester, is there any way around the requirement to have an order by the physician? What about those who do not have a PCP? And I'm assuming that Nicole means an order for the monoclonal antibody.
I would check in with your local public health department. Yes. If you've got a positive test, you've gotten it from somewhere. So you've got your positive test, and I wouldn't suggest going into an emergency department. And I'm not sure that a walk-in clinic would help you that much either, but I would call your local county public health department and say, I'm interested in getting this, where can I do it? And imagine that there's a clinic that you could get into relatively quickly to help prompt that. Yeah. I know a lot of people don't have primary care providers, and that's understandable. If you have any kind of a doctor for anything, nurse practitioners, midwives, anybody who's licensed in your state can direct you for those.
Yeah. From Larry Jacobson, he asks about the current recommendations regarding booster shots and when are they likely to be available? We hadn't even gotten into the boosters yet. I know it was on our list of things to do. So thank you, Larry, for.
I know. Okay. Right now, you can get a booster shot if you had Pfizer and you're immunosuppressed. So if you have an immunosuppressed medication like chronic prednisone use, if you have some other condition that makes you considered to be immunosuppressed, you can get access. You can't get access for age alone or for other medical conditions yet. It is my understanding that Pfizer only, so you would have had to have Pfizer in the first place, will be okayed by the FDA probably by the end of this month. So a couple of weeks from now, maybe, for anyone. And then it's not clear how this will work. And I suspect it will be left to the states, which is good and not good. It's good for me because I live in Washington State,
Mhm.
because we're very proactive here on this particular virus. But and I would imagine it will get rolled out similar to the initial rollout. So priority would be the older and the medically compromised people, or potentially medically compromised, chronic medical conditions. And that sort of makes sense because some of us got our vaccine earlier, and so we've already gone. Like I'm at 8 months already, and they're talking about 6 months for the booster, and some are even talking about it sooner than that. But I think you would want to catch up with the older population that got vaccinated first. And the reason I'm saying this, I'm not just making it up because I'm older, is that we actually have seen within our system, at least, and I believe this is consistent with national, we have seen higher breakthrough cases in older people.
Mhm.
So the question is it because they're more vulnerable because they're older, or is it because they got vaccinated earlier and now the vaccine's wearing off? Its efficacy is a little bit less over time. We know this, right? When you get a flu vaccine, it doesn't last you forever. So the opportunity to vaccinate those people who are older, maybe more at risk, but also have a longer period of time. I'm hoping that people will do it in a little bit stepwise fashion.
So, so will there, in short order, be any kind of evidence about sorting out whether it's length of time versus age, or is there any way to understand what is cause and effect? Or
I think it would be hard. The group we could use would be healthcare workers, younger healthcare workers who got vaccinated early versus older
Yeah.
people.
Yeah.
And I hope that we will get that data, but I think it's too soon to really be able to do that. But those would be the two good comparison groups to see.
Gazelle
the
Tan.
other-
Oh, sorry.
Oh yeah, let me finish the other information that is not, don't say this is written in stone, but it's my understanding that Moderna will be looked at shortly after Pfizer in terms of booster. But right now it's Pfizer is what the FDA has been looking at primarily. So hopefully by October.
Yeah. October is right around the corner. So
I know.
So Gazelle Tan asks, what are your thoughts on vaccine diversity for the booster? So wait for Moderna if first vaccine was Pfizer, or is there any evidence, or are they studying that?
There's not any evidence that I'm aware of. What the word I heard was stick with what you got in the first place. And booster with that. So I think it could go either way. It could be that it doesn't matter. You could get another one and it either may or may not make a difference, or maybe it's not quite as effective because it doesn't boost what you already had going on in the first place with the protection. So because there's lack of information, I believe is why the word is stick with what you had in the first place.
Laura Mason just added, and she put in the chat, there's an interesting article in the New York Times regarding mixing and matching. So Dawn Grell asks, for healthy young adults who are still having vaccination hesitancy, is a certain type of vaccine preferable? At the beginning, we were told to just get our hands on whatever we could. And I guess this speaks to now that we've had a bit of time and experience with all the different vaccines. Are there really big differences or not? Or
I think it would sort of depend on why they're hesitant. if they just don't like getting shots, then I'd steer them towards Johnson and Johnson because it's once and done. There is some question, as I said, about this blood clotting thing, rare, super rare. And I think what you have to put into perspective is that now that we've seen the Delta variant actually killing younger people and impairing younger people, we see physically fit, athletic people that are getting super sick, being admitted, being vented, having a long recovery, having long COVID symptoms, foggy brain, like maybe never being the same. We just don't know.
Yeah.
What is becoming clear is that there are, although it can go on for a long, long time, there are some people that seem to be recovering from that long, prolonged recovery, but we don't know who and why, and if some folks are genetically more challenged with, getting rid of it. We just don't know enough yet. So I think that I would highlight the stories of people that are just like them. They're your age and they're super sick. The people that are in the hospital saying, please, 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 I can't breathe. I wish I had done it differently. Make sure they see those stories, because honestly, we don't have a community awareness of how bad it is right now. We really don't. I think everybody was so anxious to get back to normal life, and that taste of it, that getting out and getting together with friends and being outdoors. Now it's, we're starting to see winter conditions coming along, fall, harder to do outside activities. And that's going to push us even more at risk. And, I don't know that young people are that excited about wearing masks and all of that stuff. So, and
is that why we're seeing, I know on our Sunday prep, you had shared some statistics about what percentage of people who are hospitalized were younger, and it's just like continuing to climb. So do you feel like that's the reason why we're seeing younger people, because they're not vaccinated and not masking, they're not doing the things that we know?
Yeah, I think the message was for a long time was, older, sick, underlying health conditions, everybody else will be fine, or if you get it, it's going to be mild. But, mild is not really mild. What I think like mild is like a cold, right?
Yeah,
And that's not what we're calling mild.
Well, and I think, and I think the risk of long COVID and
it's scary.
Yeah, I know people who have long COVID who maybe even were asymptomatic. I think you're going to hear a bit about that at our annual conference. So again, we hope that you join us, because we're going to kind of dive deeply into that. And I think the opportunity to have long COVID, even if you're asymptomatic or mild symptoms, and the lifelong impact of that, in addition to filling up our hospitals and everyone not being able to get the normal care or even emergency care because the ERs are filled up, should be good messaging for why we should be getting the vaccine in people who are hesitant.
Yesterday, in our prep, Dale, she's actually on the front lines dealing with this, but in Washington State, her hospital is the only hospital with any ICU beds, and all of the surrounding states are completely booked up. So for advocates, it's good to understand. We were talking about this, like, if you're trying to get somebody into the ER or trying to help someone with, like your clients or their families, they're just slammed. Like, there's not even someone to answer the phone in the ER, let alone, deal with your issue of your client. So I think we all have to be kind of patient and helpful with the system, because it's just really crazy out there right now.
Yeah, and I'll just clarify, our hospital, our main level 4 hospital, which is, if you don't know, it is by special care nursery status, is the only one that can admit pregnant, complex pregnant patients for ICU beds. And because of that, we're actually trying to keep open beds. Even just being able to monitor the babies that are at super high risk is a challenge. And we finally got one of our ICU units to be the place where they would actually hold beds for the pregnant patients. So that's for all of the state of Washington and surrounding areas where it's really hard to find the expertise to do the obstetrical care and the ICU care at the same time. So I think for advocates, it's even a tougher job right now. I mentioned the non-direct COVID complications, either worsening disease or death related. And so to be able to advocate to get a sense of what your client is about, who they are they someone who would reach out for help maybe a little before they absolutely had to, or are they someone who waits till the last minute? Because that last minute person, first of all, the one that says, I've got a headache, I've got to go to the emergency department, maybe you can talk them down, maybe you can get some outpatient other thing. And the one that tends to minimize, you really got to advocate for that person, because you don't want them to minimize themselves to the, it's too late when they do show up. There's care in some places there's not, like I mentioned, the guy that died at age 72 of his heart attack, where he went to 5 different hospitals trying to get admitted, and there was no room at the inn. So we don't have that, but we do have it limited for pregnancy, and we're constantly adjusting our levels of care. So within healthcare, there's crisis, and in some states they're in crisis condition. We are at severe contingency, which means that we are doing things slightly different. I feel like we're still providing safe care, but some of the stuff that was a little bit not elective, but not urgent, is having to be prioritized. So that is the kind of thing you're going to encounter, and understand that it's not a roadblock that's unintentional. It's out of necessity, but you might have to advocate a little bit more strongly for someone that you really feel uncomfortable about not getting care. Mm-hmm. And we have just to mention that part of the reason for this is that we have nurses leaving the specialty altogether. We have not enough nurses to go around. I have empty beds and not enough nurses to staff them in the facilities that I work with. And I'm seeing this across the state of Washington. So it's not any different anywhere else in the country. People are leaving the specialty. People are home because they were exposed and can't come to work and may not be vaccinated. If people are home sick with COVID, they might have gotten it from their kids from school. So we've got all this kind of flurry of re-exposures. Mm-hmm. And kids need to be in school. Don't get me wrong. I think very strongly kids need to be in school, but that has to be done safely too. You can't just send them back to school and expect that whole communities are not going to get ill from that. So other questions, I just wanted to make sure you really sort of level set, because I don't get a sense from the patients that we take care of and from the community I live in that people really understand how bad it is.
Mm-hmm. Yeah, can you also mention the limitations on visitors that you talked about yesterday, just so people know, so people understand?
Yeah. So we had liberalized our visitor policy, not wide open, but for 2 that could switch out, 1 only being in the hospital at any given time for all of our patients across whatever reason they were in the hospital. And we also had open up surgeries to more electives or kind of semi-elective, not urgent. So we had to back off on that. And we had to go back to 1 visitor only for all of our hospital. Our OB and our NICU, our neonatal intensive care unit, has allowed two, because usually there's two parents or a parent and a significant other who's a caregiver for babies and for kids. But again, trying to switch them out one at a time. So it's tough on families when, you've got a very sick, brand new baby and one at a time can only be there, that kind of thing. And for our delivery service in our particular system, we have one support person plus a doula, so they're OB advocates, right? Or for those who either can't afford or uncomfortable with a doula, we allow a second support person, but just for the delivery and now not for postpartum.
Yeah.
So it's tightened up, and I think people don't understand it. They're tired of it. I totally get it. Our providers are getting burned out because they are working so hard because there's not enough of them. So if there's a way to be patient, if somebody is not as respectful and polite as they might normally have been, maybe you can step back and reconnect. I mean, I think that's what advocates are so good at, is to be able to sort of level set with the person that you're representing, but also still say, hey, I know it's crazy for you, but this is really important. I'm worried about this person that I'm, responding to. And you may have to go back to some virtual support or some phone support if you can't go in.
Yeah. One of the sessions that we're going to be covering at the conference also is how patients are rethinking their access to care, and certainly, utilizing different ways to seek care. And the advocates are so important in making sure that happens. I want to get in Deirdre Totten's question about, should one get the flu shot now before the booster becomes available?
Yeah, I mean, unless you're immunosuppressed and you can do both at the same time right now, I would get your flu shot. We're not seeing flu yet, but I wouldn't. If you super hate getting shots, you can, and you think you're going to be able to access if you had Pfizer before, but if you're waiting around for Moderna or whatever, we're getting into mid-October or later, it's better to be protected for flu. I just a little nervous about it this year.
So will the boosters interfere with the flu, or what's okay?
No,
So,
you can get them all at the same time.
okay.
If you need a tetanus shot, you can get it. There's
Okay.
no waiting. If you had COVID, if your clients had COVID, they can get vaccinated within, I think the least amount is 2 weeks, but I'd wait 3 weeks because some of these folks already still have antibodies circulating. So get them. And they may, if they're really sick, we know that they shed. We don't know if they're infectious. But some of our pregnant patients are in the hospital vented for weeks and weeks and weeks. I mean, it's really,
that's awful.
We're seeing the Delta, we're seeing some bigger effects on younger folks that I think, again, in the early stages, younger people didn't see themselves getting sick very often. And so just that reality is important that we let folks know about.
So we have 3 more minutes of your very valuable time. So can you help us level set as we're heading into the fall about what we could and should be doing, what we likely will be seeing, and what we all on the call can be doing to help get us through this fall to winter?
Yeah. I would say, and this is not going to sound uplifting at all, but so COVID is not going to go away. It's going to be, hopefully it will settle into a season, like flu has a season. And we will have vaccinations that will be modified every spring based on the fall before, or the whatever season it is, variants that are out there, and we will mostly be fine. And yet, I think we've learned some things that we probably should have been doing for flu season anyway, which is the distancing and masking when you're in an enclosed space out in public. It's probably a good thing to keep doing. There are countries that do this all the time when it comes to flu season. I think that this current spike is going to take quite a while. The research would suggest that it's going to be a broader peak and that it will come down, but will stabilize, and it will stabilize at a midpoint, not as low as we were when we started opening everything back up again. And so I think we just are going to need to be a little bit cautious when we're around other people for maybe forever, for certainly for a long time.
Mhm.
And if we reset expectations that it's not going to entirely go away, then we can get back to the things we like to do and just be safe about it.
Mhm.
Like my daughter-in-law is pregnant, and I'm having a family only shower for her, and only vaccinated people are allowed to come.
Mhm. Yeah.
And it will be inside. There'll be family members, so mostly they'll be okay. But I'm going to open it to do a little Zoom for when she opens her gifts for the people that either can't travel
Mhm.
or won't or can't be vaccinated. So you can do stuff like that. That's a little bit, and I didn't think of that. That was my clever daughter. That makes it be not excluding people. I mean, I have an anti-vax member of my family, and at least she will be able to attend virtually.
Mhm.
And I love her. I don't want her out of everything,
Right.
but I don't
Right.
understand her, but I love her.
Yeah, yeah.
Yeah,
And
yeah.
that is what we're all grappling
That's
with.
what we're all about, right?
Thank
And
you.
if anyone listens to the Daily and the New York Times, there's a really great session today about anti-vaxxers, and it would be probably interesting for you.
Yeah.
Yeah. And don't kill yourself trying to convince somebody that really isn't interested in vaccination, because it's not going to change them. It's going to create adversity and might change your relationship, and it's not worth it. But you should be able to level set what your expectations are when they're around you, or if they're not around you. And there are some people that are vaccine hesitant, and they're the ones we should focus on. And
Absolutely.
that's why we've gotten very more directive with our OB patients, because we want them to understand that we fully support it, and we're worried about their health. And with pregnancy, it's even better, because you pass that antibody onto the baby who can't get vaccinated, and it's also in the breast milk when you feed the baby. So it's like a win-win-win.
Yeah. Yeah.
Yeah.
Well, so thank you so much, Dale. We know that your life is really crazy right now. So
It's a little busy right now.
it's
Yeah.
really busy.
Yeah.
So thank you for the time that you've spent in really preparing for this call and being available to answer questions from the community. And we're wishing you a lot of safety and gratitude for helping our community understand the most recent stuff around COVID. So thank you.
Yeah. And thank you to the community, the folks that tune in. And I know anything that you know and do, expands to every person you make contact with. So, we will not quit trying to make advocacy be something that's front and center for every single person in this country.
Yeah.
So thanks.
Thank you. Okay. Bye,
Thanks, Dale.
everybody.
Bye, everybody.
Bye-bye.